Question from the other room?
Gotta go to the other room.
Yes,
They're still here.
Hey, Senators, can you hear me all right?
Yeah, hear you well. Thank you.
Hey, first thing is get everybody to clap. Let's give a big hand to the folks who dished out the food for us tonight. One of the concerns that I have with regards to, by the way, my name is Carl Schwolman, I'm from Portland. One of the concerns that I have is that we're passing the payment from private industry to public industry, but we're not getting to the underlying issues like tort reform and other issues that could lower costs. The other concern that I have, that both of you did, was put two words together that don't make sense to me: government and efficiency. Social Security is underfunded, Medicare is underfunded, Medicaid is underfunded, Fannie Mae's got problems, Freddie Mac's got problems, and I keep reading that Ginnie Mae's going to have problems. Why in the world are we going to take this on?
Well, first of all, we have really, I think, at this point, no choice. The direction that the healthcare system is going is not a good one right now. As Jack said, it's unsustainable. Unsustainable means it can't last. We simply can't afford family coverage that costs $26,000 a year in 2016. We can't afford what it costs now. We have to do something about it. The government's role in this is not to take over from private industry. It's to supervise and set the market conditions for private industry to compete on a fair way. And I would hope, because I'm an advocate for the public option, to be able to lay down a competitor side by side so that you're not purely dependent on the private insurance industry to manage our way through this. They haven't shown a very good job of getting there so far. And ultimately, I guess I have a little bit more confidence in the people who run the U.S. Marine Corps and put a man on the moon and put a lander on Mars and run nuclear submarines safely around the world, down at the bottom of the canyons of the ocean every day than I do the private insurance industry.
Made that most of the tasks the government takes on, the private market specifically rejects because it's too expensive, it's too difficult. In 1965, 1963, if you were 63, certainly before Medicare, if you were a senior and you tried to buy health care insurance, guess what? There was no private market. You had a pre-existing condition, you were not a good insurance risk simply because of your age. In fact, I've seen some people in this room remember that either your grandfather or grandmother was living in your house, you were paying for her health care, as well as sending trying to get your kids through school, and there was no private market solution because it didn't make money. You can't make money on the Medicare system. But what you can do is give people what I think they, and Phil and I both agree, deserve is adequate health care. And that, so when you take the public entities especially, oh, by the way, the VA system is probably one of the most efficient hospital systems in the country. Well, listen, they're out there and they are doing a good job. They've got information technology, and there are people, I know, when they come in, they're flocking to get into the VA system. So.
I said the student from Brown, the medical student.
Hi, my name is Reshma. I'm a medical student at Brown University. I'm also part of the American Medical Students Association. And I was fortunate enough actually to be in DC during the markup and watch you guys form the health committee bill. So really appreciate your efforts in creating hopefully a robust public option. is what we're all aiming for. So my question is actually a concern from a medical perspective. I've worked in emergency rooms in which many people come in using the emergency room as a primary healthcare source. And a lot of the times these hospitals have to incur these costs as a result, and it drives up other patients' premiums. And so my major concern is, what is the public option going to do in terms of everybody else's insurance, the insurance that they have and they're satisfied with, while serving the people who don't have insurance or who are underinsured? And how is it going to help improve quality of care?
Those are two very, very good questions. The public option by itself doesn't solve the cost shifting problem that if you pay for insurance now for yourself and your family, you have on average maybe $1,100 or $1,200 worth of that price. That actually isn't paying for you. It's paying for the uninsured people who come to the system, the people for whom the hospital can't get compensated, but it can't go broke either, so it has to find the money someplace, and it compensates by charging insured people more. So it's about $1,100 or $1,200 a year by most estimates that I have seen. Once you get everybody covered, that ceases to be a problem, and that's an immediate savings towards those people who already have coverage that they're paying for. And so it balances that out. On the quality side, that's where I think the public option can make the biggest difference. Because we've seen the private insurance industry have many years to try to make quality improvements work. And they frankly haven't done it. You all know as doctors, it's not the problem with doctors that causes 100,000 Americans to be killed every year by medical errors and hospital-acquired infections. It's a systems problem. Somebody comes into a very complex organization in which a lot of people have to do a lot of things, and it's usually not pilot error or an individual person's mistake. It's a systems problem. And the insurance system needs to be willing to pay to reform it, and then you can save money from those costs. I'll tell you, I founded something in Rhode Island called the Rhode Island Quality Institute. And one of my educations came from a discussion I had with the hospitals, because we started this program where all of the intensive care units in the state agreed to take on new responsibilities that would lower the risk of line infections, catheter infections, respiratory complications, all the things that are avoidable in an intensive care unit, but take a lot of effort and a lot of perfectionism to avoid. And they said it would probably cost about $400,000 per year to administer that program. And I said, because we've been talking about this for a while, I said, but you've estimated that the savings in less hospital days and less consequences, quicker exits and all that from the ICU will be $8 million a year. What's not to like about spending $400,000 to save $8 million, right? And they said, no, you have to understand the math of healthcare. The $400,000 we spend it. It's our money and it's gone. The $8 million that we save, that doesn't save us $8 million. That, for us, is $8 million less in revenues. Because we get paid for those extra days that people stay in the intensive care unit. So we want to do this. We know it's the right thing to do. In fact, every single Rhode Island hospital signed up for it, and they're doing it now. But they're doing it against their financial interest, because the private insurance industry hasn't been ponying up to make those investments, even though they're the beneficiaries of it in the long run with the $8 million. And so there can be, I guess, very short-term thinking on the part of the private insurance industry sometime, and that's where I think a public option comes in. It can say, look, we know that we're going to end up with Americans on Medicare. We know that we want to turn the direction of this healthcare system instead of in the direction of higher quality. We're willing to take the effort to get in there and support this intensive care unit reform. Why should the Rhode Island Quality Institute have had to do that? That should have been something that happened organically, and it didn't for a reason. And the public option can have a big, big role in correcting that reason, and so that we can not just save the $8 million in the Rhode Island intensive care units, but also throughout the rest of the healthcare system. There's, again, I said at the beginning, there's as much as $1 trillion a year in waste and excess care in the system already. We need to find the ways to make that cure itself. And that's where a lot of the money will be saved, to answer Allison's question. Carol has had his hand up for a while. Let Nick hang on to it, it's our policy.